So what we're going to do today is going to be very similar to what we did last week. And it's based on the ECHO model of kind of care and ECHO model of information sharing. And so what we're going to do is we're going to have about a 10 to about 12-minute kind of educational module, which today will be on language of medical billing. After that, we will have a case presentation by Hannah Fjeld over at Providence. And so she'll walk through a case that she had a question about billing. We'll walk through exactly how to bill that, and our panel of experts, Zach and Andrew, will help us to kind of walk through exactly how to do that. And then we'll have it open for questions. So if there's any additional questions that we have that have come up kind of in this initial process, we will walk through those and see if there's anything that we can potentially help with. As a reminder, if you have any questions, and you don't feel comfortable asking, just pop those into the chat or send me a text and I can reiterate that to the group. And then we'll take notes from this. And at the end of the session in the next day or so, you'll get an evaluation kind of on this, as we want to continually build and make this a better kind of experience for everyone and a learning opportunity. So without further ado, I'm going to turn this over to Zach and Andrew to talk about the language of medical billing 101.
All right. Thank you, Renee. Once again, I'm Zach Roscoe with A to Z, and Andrew Hibbert is also on the phone today. This just kind of a caveat, we're going to go through a language of medical billing in a fairly short amount of time. When we talk about this topic in presentations that aren't as time-bound, we usually spend roughly 2 hours on the topic of contracting, credentialing, and privileging. So we're going to be going over very high-level information today. But if you do have questions that come up, we can start to address these a little bit in future presentations, and some of it we can answer via email. And we have other resources available if you do end up having questions. But today, the intent is to really go over just some of the common terminology you're going to see as we dive into medical billing. And some of these pertain more to specific payer types than others. So we're going to go over credentialing, enrollment and enrolled providers, billing versus rendering providers, contracted provider, network status, and privileges, just very briefly. So just to start off with, what is credentialing? We hear about this a bit, and this often is cited as one of the largest barriers to pharmacists getting involved in medical billing, is that they aren't able to be credentialed. Quite simply put, credentialing is the process by which an organization verifies the credentials of a specific healthcare provider and ensures they have the requisite licenses, expertise, certification to perform the services they're applying to provide. It is a multi-step process. It can really be broken down into 3 different steps: data collection, data review, and then the awarding or rejecting of credentials. I think it's important to call out, this is where a lot of confusion that comes into play, is that there's multiple types of credentialing, and we talk about it both internally and externally. And when I say internal credentialing, we're generally talking about at your practice site. Most practices have some formal process. A lot of independent pharmacies, so pharmacies that are branching into clinical services, may not have this established at this point. And depending upon your type of practice site, it may not be a requirement, but it's always a best practice to have a credentialing process internally. And much of the 2 credentialing processes overlaps. They're both can be applied to individual practitioners, though payer credentialing also is applied to practices, so the actual facility. Practice or internal credentialing and external credentialing both involve that collection and validation of the data of the practice or the provider's licensure and expertise. But the intended outcome of each of these 2 processes, the internal credentialing, practice credentialing, and external credentialing, are different. The desired outcome of practice credentialing is the granting of or advancement to privileging. So getting authorized to be a provider at a practice and then being able to be given privileges so you know what your scope of practice at that site is. The difference on the payer credentialing side is the intent is to generally gain a contract or be added to a contract that's already established. So payer credentialing, the intent is to be able to be determined by that medical plan as an eligible individual to provide services. So as an example of external credentialing, this is a notice from Providence Health Services back in 2017 when we first applied. We have some commercial and some managed Medicaid Providence services at my main practice site. And this is indicating what you kind of see as a response. A lot of times you'll get a no, we don't credential pharmacists, or we haven't credentialed pharmacists. We have to think about how to do that, or maybe let's have some discussions. But some medical payers, and a lot more at this point, are going to have this as a standard where they've already credentialed pharmacists, or they will credential pharmacists. But this is an example where we were granted credentialing. And as you can see with external credentialing, it notes that the next step is contracting. And another note to make is that it's more on the commercial side where you go from credentialing to contracting. It's a little bit different of a process when we talk about federal or state payers, so Medicare and Medicaid, and we'll touch on those in a moment. Just diving a little bit more into the medical contracting section. Medical contracting, obviously that's pretty straightforward. That is the process of establishing a contract where a provider or a practice can provide services and be reimbursed for them under a specific medical benefit plan. And this is going to detail a lot of what you can do for patients of that medical plan, certain requirements you have, how you're going to get paid, and it'll also attach you to specific plans. So much like with a pharmacy benefit, when you have you may have a whole bunch of Optum plans with the same BIN and PCN. You have different groups that are going to dictate what the plan details and coverage are. Just because you're in network with United Healthcare doesn't mean you're in network with all United Healthcare groups. It's a little bit different. And there are certain groups you have to directly apply to, certain ones that'll automatically be applied. But when you actually do the medical contracting step, it's going to determine which groups and which plans are going to be attached to that contract and which providers. So this all starts with generally a contract application or a request for participation. You then advance to a review of applicant qualifications, which is our credentialing process. Then if you are credentialed, generally you are then advanced to the provision of a draft contract. You then get to review and negotiate the terms of the contract. That's also an area that contrasts from pharmacy benefit manager contracts, is that you actually have some ability to negotiate here. You can get things modified, changed, you can negotiate rates. And then if you come to agreement, you execute the contract, and then you can start providing services. And this process continues to cycle through as you go through negotiation or contract renewal. As kind of a contrast to this process, when we talk about the contracting process, that is primarily your commercial plans, and that is any type of managed care plan. So we're talking managed Medicaid, managed Medicare plans, where you are directly contracting with a separate entity to provide services. When it comes to state programs, so fee-for-service Medicaid or Medicare B, we're talking about a process of enrollment. And enrollment essentially equals contracting and credentialing from Medicare and Medicaid. The difference is you aren't going to be signing a separate specific contract. You're enrolling as an in-network provider, and your contract, the terms of your contract are the laws. So they're either federal rules under the Medicare program, or they're state rules under the fee-for-service Medicaid program. You typically are not awarded or sent a contract to review and negotiate. In this case, you are simply listed as an enrolled provider, and now you are responsible for understanding and following the law, either federally or in the state. Moving forward to billing provider and rendering provider definitions, we hear about these a lot, and this kind of comes into play more with the actual process of billing. When you're submitting a CMS 1500 form, you're submitting a claim for reimbursement. There are two fields on the claim form itself where you have to list the rendering and the billing provider. In most cases, the billing provider is the practice or is an entity billing on behalf of the services of an individual provider. So the billing provider often will be the pharmacy, it'll be an FQHC, it'll be a medical practice, all of which are going to have their own independent NPI. So the NPI of that billing practice who has received assignment of benefits will be put in that box. In some rare cases where you still have a small independent practice, that's just a sole provider, and they may not have set up a separate name or contract for the practice, and they've actually contracted as an individual. There are situations where that provider would be both the billing and the rendering provider. And then simply the rendering provider is the provider who actually performed and bills for the services. And I can't recall if we have a topic later on incident to services, but I will call it out here. Even if a service is billed incident to, meaning that's a Medicare term, so a Medicare recognized provider is billing for the services of a pharmacist or a nurse or someone else under their supervision, the rendering provider is still that Medicare provider. When incident to services are provided, Medicare doesn't know who actually perform the services because they are billed as if the supervising provider is the individual who actually performed it. So your NPI, if you're billing incident to, is not going to be on this form. And then diving into network status, this is what is your status within a medical payer network? Are you a participating provider or a non-participating provider, or shortened to non-par? This is also an area where we tend to see a lot of confusion because credentialing does not mean you're a participating provider. A participating provider is either a practice or a professional who has been granted both credentials with a medical payer and has been attached to or awarded a contract. So it may be surprising to some of you, but even if you have been credentialed by a payer, you can still be an out-of-network or non-contracted provider. And this happens a lot of times with group practices where the practice may have an established contract with a medical payer. And in that contract is going to detail specific terms such as all providers you hire have to meet certain criteria and they're automatically grouped into the contract, or within X days of hiring a new provider, you must have them submit for credentialing and they're out of network until they're credentialed. So this can be very hard for patients as they may look up a facility on their insurance website and find an in-network participating provider practice and be referred to a medical group. And then the individual provider they see is not actually credentialed with that payer and then may get hit with a full bill or a larger out-of-network copay. So a provider who is only credentialed with a medical payer or is neither contracted nor credentialed with a medical payer, they're going to be out of network. And a provider who is contracted at a practice practicing at a contracted practice, but is not credentialed with the medical payer or not attached to the contract is also going to be considered a non-participating provider. Typically, when you are credentialed, you may be added to the health plan's registry. It speeds up the process of medical billing and reimbursement. Sometimes they'll list you on their website at that point, but when it is the contracting status that helps patients when they start searching in a medical plans database, when they're searching for participating providers, you'd have to have both of those steps met to show up in that search if the medical plan is actually putting the pharmacists in that registry. Sometimes I've seen it once or twice where they have pharmacists in there, but typically they're kind of hidden behind the logic, and I haven't seen us represented uniformly on the medical plan websites yet. And that brings us to the end of the presentation. I didn't have a whole slide on there on privileging. I apologize. I should have had that in there. I think it fell off. But going back to privileging, I mentioned it earlier when we talked about internal credentialing. Once you are credentialed at a practice, typically then you advance to internal privileging, which is where the either supervising pharmacist, so the PIC, the medical director, the lead clinical pharmacist, someone along those lines will have been delegated authority to grant you your privileges. So once a review of your background, licensure and experience has been conducted and completed, there's then a step internally of privileging where you dictate these are the services you are allowed to provide clinically at this facility. And if you're at multiple practice sites, you may have different privileging at each one. So you may be allowed to administer drugs in one location, and at another site based on their licensure, you may not be able to. So it is important to know your privileging as well and have a process for privileging so that whether it's you performing services or you supervising staff, and making sure that they are practicing appropriately and within their bounds, your facility should have that process to make it very clear to all individuals what they're allowed to do and what would need to go to a different location or different provider.
Perfect. Thank you, Zach. So we did have one question in the chat. If you could just expand on the differentiation between credentialed and contracted.
Yes. So credentialed simply means that you are a provider. So I guess I'm assuming that means external credentialing with a medical payer. So credentialing with a medical payer means you are a provider who meets their baseline qualifications to provide services as a provider of that type. That may be that medical payer X has decided that they want pharmacists who they're going to credential to have either completed a residency or be board certified in one of X specialties and have maybe X years of experience and no action or restrictions on their board license in the state. So once they have verified that information, verified your license, your degree, your background check that you don't have any previous malpractice or board action, they will then say you are a credentialed provider with us. And like I said, sometimes that will put you on their website and saying this is a credentialed provider who may be eligible for reimbursement from us. It doesn't say you're attached to a specific plan. It just says you are an approved provider of this specialty. Now, what's the benefit of getting credentialed without a contract? One benefit there is if you're submitting claims as a non-participating provider, it's going to speed up the processing time, because a lot of times you can still get reimbursement as a non-participating provider. The reimbursement and the patient copay may vary, but it's a prolonged process if they don't have any information about you, don't have any information about your practice, and they need to essentially do a claim by claim level of credentialing. Is this person eligible to provide this service? Contracting, on the other hand, says you can provide the services within this contract for the group of patients identified. And that may be multiple service lines. This may be all of the commercial plans that this medical payer offers in your area. It could be all of their Medicare Advantage plans. It could be just their managed Medicaid plan. So the contract is going to actually make you an in-network provider where a patient can go to you and they will be charged a copay as if they're seeing a network provider. It'll define if you are in network or, if you are a specialist or if you're considered a primary care service. And it will also define how you get reimbursed. There's a multitude of mechanisms for reimbursement where it could be just a fee for service rate. So you get a flat rate per code in a specific amount defined. It could be 80% of your usual and customary charges. It could be depending upon your specialty, it could be a per member per month for patients you're seeing. So there's a lot of details that will go into that. But the difference is one actually allows you to be in network. The other one is simply saying you are eligible to be a participating provider if you were to advance to contracting.
Perfect. Thank you, Zach. All right, so now what we'll do is our second part of the training today, we'll actually have Hannah Fjeld give us a little bit of a case that she has a question about, and then we'll walk through some of the specifics. So I have her slides up right now. You'd be able to see those, but you also have a more detailed version of the case that she uploaded to the system. That was a Google form that provides you a little bit more information, but this will provide kind of the big highlights that she's used to determine the case. And so I'm going to hand it off to Hannah, and then Hannah, as you need me to switch slides, just let me know.
Okay, perfect. So yes, this is a billing question that I had to make sure we're billing correctly in our clinic, something that comes up pretty often. So my main questions were medication administration charging and adding an E&M billing code to those kind of visits, or just doing a medication administration charge, and then differences based on insurance types. Next slide, please. So this is kind of a brief overview of the patient. A 74-year-old, she comes in, a new osteoporosis diagnosis, referred to pharmacy to discuss the medication treatment options with the patient. Ends up deciding to do Prolia. And so we end up giving Prolia administration in clinic. Some patient information just showing that she has osteoporosis. All labs are appropriate for Prolia administration, and then also assessment of her medications in terms of she's on omeprazole for GERD, reason that we were avoiding a bisphosphonate. Specific services provided, so we discussed treatment options and did shared decision making on that treatment. We did lifestyle counseling, so with osteoporosis, looking at are they active, are they doing calcium, vitamin D supplementation, or getting that in their diet, smoking, alcohol, those kind of things. There's something that we talk about. Do medication reconciliation and make recommendations in terms of if they're on omeprazole, have they tried to come off of it, maybe an intervention there. And then we administer Prolia in clinic, and then order labs for Prolia monitoring are things that I did for this visit. Next slide, please. So medical billing information, I said the place of service was in office. Code type, I did E&M. Insurance type, for this example, I did Medicare, but I'd be curious to see what other billing would be for other insurances. So like if they had private insurance or Medicaid. Most common for Prolia, we have our elderly population, so most of them are Medicare, but I'd be curious to hear the other insurance ones too. All of our patients are always established. For number and complexity of the problems assessed at visit, I said moderate. Amount of complexity of data addressed at visit, minimal to none. And then risk of complications, morbidity and mortality to patient, moderate, since we started the medication. And the CPT code is really where my biggest question comes in right now in clinic. We just do the 99999. And then charge for that administration of Prolia, but we don't do any billing for our visit. If it was Medicare, we can only bill incident 2. So I was thinking 99211 if we did bill for the visit. If we were able to bill higher E&M codes, like if it was a private insurance, I think it would be a 99214, but all question marks, which is why I brought up this case.
Okay. Great. Thank you for bringing this case. Before we go into what codes would be appropriate and how you might address this with different payers, I do have a couple of questions about kind of the timeline and the mechanism of ordering the medication. So first, Andy and I were talking about this a little bit earlier. Is the order for the Prolia being placed by the pharmacist in the clinic? So is this a visit where you're determining what the treatment approach should be for this patient? You are ordering the Prolia, and then in the same visit, administering the Prolia to the patient? Or is there an order coming from a different provider at the practice says, we think this patient should be on Prolia, let's order it, and then send them to the pharmacist for education and administration after maybe a PA has been done?
So for this patient case, it was discussing the options with the patient. So going through the different options and then using shared decision making, deciding on Prolia. And so I ordered it under a collaborative practice agreement under the provider. So not under my name, and then administered it that day as well.
That day. Okay. Okay, great. So that's kind of what I took from your submission, but we have seen all different practices. So we wanted to be very sure when we go over the results. So I would state that if there is a medication administration that is occurring on the same day as the visit for the evaluation and management of, in this case, osteoporosis, then there's going to be two separate services performed. There's evaluation and management, and then there is the procedure of administering the medication. Now, it is going to be important to separate that documentation in some way for proper billing, especially if you're billing based off of time, because you would need to keep the time separate. But in this case, because the condition for which the medication is being administered, a plan of care has not yet been detailed, you are evaluating an uncontrolled chronic disease state, and you are now initiating a prescription medication. So kind of going back to our E&M levels for an established patient for an office visit. So we know it's an evaluation and management service for an established patient. So we start with 9921. And then let's say we're billing off of the medical complexity. The problem of a chronic disease state, uncontrolled, puts you at moderate on the problem points. We're going to ignore the data points here because that's typically the lowest. And we have a prescription drug management being ordered. In this case, one that the patient hasn't been on before. It's parenteral, so it's, you can kind of argue risk of certain medications, but according to AMA, prescription drug management is going to be moderate. So we're at that moderate level of complexity. So I would agree, this could be a 99214. Andy, would you also agree? I'm not sure if you are connected, so feel free to jump in, but I'll keep moving forward. So yes, I think that could be a 4. Oh, Andy, I did see you came off mute.
All right. I unmuted my phone and not Zoom. That's a 99214 all day long, even when you include the data.
Yeah, even when you include the data. Yeah. So that being said, we now have to look at the administration of the Prolia. We're not going to go over all the different codes for medication administration in today's presentation. We have a topics section a little bit later on where we'll go over more of the common medication administration codes. But I would say there is a specific procedure code for medication administration that covers both subcutaneous and intramuscular injections. That is 96372, if I'm remembering correctly. And that would be the code we would be billing here for the medication administration. Now, another area of kind of question, I'm guessing since you were able to bill it the same day, this was not patient supplied medication, this was clinic stock. This is something that you had stocked in the clinic?
Yes.
Okay. So in that case, because you have it stocked in the clinic as well, you also have to bill for the drug. The 96372 is just billing for the procedure of injection and the associated assessment and monitoring of the injection. So then you have to also bill a third code, a J code specific to Prolia. So all liquid or injectable medications generally have assigned CPT codes, and they're going to be based on the number of units. So you want to review how many units are associated with each code, but you would bill a J code for that drug itself as well to make sure you get reimbursed for the cost of the drug, the procedure of administering the medication, and the evaluation and management code. Now, because there are multiple services being performed on the same day, we'll talk about this in another presentation as well, so I won't go too in depth, but you are going to need a modifier on the evaluation and management code to indicate that it was a distinctly separate service from the procedure. So that's a modifier 25 would need appended onto that 99214. That should indicate to medical payers that we did not include the work of this procedure in the E&M code that was billed, and it was a separate service that is not usually a component of the billing of this initial code. So that technically you should have 3 different line items with a modifier on the E&M code.
Okay. Thank you, Zach. So double checking, Hannah, did that answer your question? And I also see that Amy has a question as well.
I'll let Amy jump in.
Thanks for the help on this, Zach. So I have a couple, because we do same service, Prolia, same health system. If the provider sends a referral for osteoporosis management and they're like, because they know we do Prolia, so they're like, oh, I think this is a good candidate for Prolia, but you're still sitting down with the patient, going over their DEXA scan and, you know, helping them understand what that means, and then ordering the drug and giving it in the visit. But does that still count? Because even though the provider identified that they're likely a candidate for Prolia, we're like, can we still do the E&M for that? Because we're still evaluating their osteoporosis, still confirming with the patient that this is what they want, and then ordering the drug and administering it in that visit.
I'm going to ask a few follow-up questions as well, and I'm going to give you my impression. And I think one of the benefits of having both Andy and I here is I tend to take the side of providers a lot more, and Andy's on the health plan side, so he can reel me in sometimes. So we'll give him an opportunity to say he disagrees with me here, potentially. But I guess my first question before I respond is, if they don't meet criteria, or let's say in discussing with the patient, they prefer to try an oral agent, does your protocol include that?
Yeah. Yeah.
Okay.
So if they could get all the way to, like, I am pretty confident I'm meeting with them to administer Prolia, and we sit down and talk about it, and they're like, oh, you know what, I don't think I want this. You know, can I just try the bisphosphonate instead? And so we can send the order in for that instead.
Okay, great. So I would say absolutely you can. This is not going to be different than, you're just an internal specialist as opposed to an external specialist. This is not different than when a PCP says, I've got a patient with heart failure who needs to start medication therapy. I think let's say Entresto or whatever, but they're not comfortable writing that order, and they send them off to a cardiologist. The cardiologist may use a lot of the assessment that's already been done, the workup from the PCP, but they're going to do their own independent workup and assessment and determine, is it appropriate to start this, or do we start something else? You're doing the same thing. So as long as the order wasn't already, I've written an order for Prolia, I'm sending you to the pharmacist to be educated on administration or the drug and then start it, that would still be an evaluation and management encounter. If they signed the order, send them to you, you're just going to be, and then you educate them on the drug, just ensure that it's safe to continue with the order as written. That's just a medication administration encounter, potentially, depending upon some other services, maybe MTM plus med admin. But yes, you absolutely could.
Okay. And then, so I guess a follow-up to that is, we are, even though we have a collaborative agreement, like when I put the order in, or Hannah puts the order into Epic, I'm signing it, I'm changing the ordering, I'm changing this authorizing provider to the medical provider, not us. Would that disqualify the E&M, or we should put it as us?
Very good question. I get this a lot too. The independence in prescriptive authority or practice authority does not equate to billing ability. And a great example is, there's still many states where nurse practitioners, I'm in Oregon, so NPs and PAs are completely independent. They don't need physician supervision. there's still plenty of states where you need a collaborative practice agreement for a PA or an NP to prescribe anything or perform any services. They can still bill as individuals. It's no different with a pharmacist under a collaborative practice agreement. Our prescriptive authority does not have to be independent for us to bill for the service. The service we're billing for is the provision of the evaluation and management, regardless of if it's under protocol, of which you probably wrote anyways. So, I mean, just kind of thinking of that, but no, there's no regulation that you can only bill if you independently prescribe.
Okay. Sorry, last question. So for new patient versus established patient, my understanding was if it is a patient that is new to me for the condition I'm seeing them for, is that then I can do it as new? Like I've never seen this person ever, even though they're established in my clinic. Is that not the case?
So that's not necessarily the case. If you are, let's say you are working in a practice that just specializes in osteoporosis, you're literally in a specialty clinic and you're receiving a patient from primary care. So if a patient is moving from primary care to specialty care, and you're the first provider at that practice, at the specialty care to see them, that would be considered a new patient to you. If you are in the primary care clinic receiving a patient from primary care for a subspecialty you have in primary care, you're still a primary care provider at that practice, and you're under the supervision of the referring provider, most typically under the CPA. So that is considered an established patient. So
okay, I haven't been doing that, but I just was always kind of a little confused by that. So like, for instance, for Hannah and I, who are working in this same clinic and receiving referrals from just those providers in that primary care clinic, it'll never be a new patient for us. Right?
Yeah, if you are taking patients on a referral basis in primary care, your specialty's primary care, you're always going to be established patients for evaluation and management services. There's differences when it comes to if you were billing like the AMA CPT codes for MTM, where that may be a different story.
Okay, cool.
Yeah.
Thank you.
Andy, I want to give you a chance to, from the health plan side, do you disagree or push back on any of that interpretation?
I don't disagree with it from a billing and coding standpoint, but from an operations standpoint, you have to be careful. For the record, I hate this case from a health plan standpoint, because this is where a lot of it's so nuanced here. It is really so nuanced. And if you're ever operating under a CDTM, just know it's always going to be an established patient by definition, because the patient's going to have to be referred to you from a provider that you have a relationship with. And it's attached to that provider. Unless you have independent authority within that state to see that patient initiate that drug without a CDTM, they're always likely going to be established. And that's kind of how I keep it easy. For the use of the codes itself, there's a variety of ways you can take this. The way that we've been highlighted here, it sounds like this is an E&M visit with a modifier 25, billing a drug administration code and the J code for Prolia. The trick here from a health plan standpoint, from a billing standpoint, in which you're billing and coding people, is how do we distinguish this as a separately identifiable services that's different from the evaluation and management? And that is where it gets hard, because a billing system is going to see those ICD-10 codes being the same and kick it out and saying, oh, no, this is not billed correctly. So there's going to have to be some type of variation there in terms of what ICD-10 code you put as primary versus secondary when you bill that drug administration code. Most practices, I'd say 90%, just do it on a different day. You know, this is likely to require prior authorization. That doesn't happen immediately. It usually takes, 24 to 72 hours. That's defined by federal law. So having the patient come back in and administering the drug is more cleaner than billing it on the same day of an evaluation management, but that doesn't make it wrong. And that's the important point I'm saying here. That does not make it wrong. It just means from an operations standpoint and how we reimburse and use data to, algorithms to say this is a clean claim or not, you get in a lot of trouble here. Not just pharmacists, all providers. It's by far one of the most commonly complained about issues with billing and reimbursement on the medical side. So I agree with Zach's interpretation of it. That's how it's completely above board. Now it may get kicked back and it may have to be, brought to the health plan's attention that this is an appropriate code, and they may have to manually override their system to approve it, which usually requires some type of PA or outreach to the health plan itself. Which is why a lot of practices have just said, okay, we're gonna do an E&M visit. We agree on the Prolia. We're gonna follow up in 10 days, 14 days, and we're gonna administer that drug as 2 separate visits. That's really clean, because from an audit perspective, what you're trying to do as a practitioner and what the auditor is looking at is what components of the evaluation and management visit you build is separate from the portions of the procedure for drug administration, which also includes many aspects of evaluation and management by definition. All procedure codes, be minor or major, have mandatory components of evaluation and management built in to the code itself. So you have to clearly distinguish what parts are in the office and outpatient E&M code that are in E&M and what portions of an E&M code are going to be in the drug administration code itself.
Yeah,
and then you have to talk about and how these things change across lines of business. And
Yep.
from a Medicare standpoint, you're talking about incident to billing, right? So this has to be an established treatment plan, and that you are pursuing it under the provider supervision as if they are providing service. Now, the CDTM, you can point to this CDTM, and this is the established treatment plan. Does a claim system know that? No. Do most billing departments know that? No. Do most health plan billing departments know that? Absolutely not. So there's going to be some type of discussion initially before this becomes a successful service that you're able to bill consistently and get revenue. There's going to be some barriers and hiccups and some conversations that are going to happen from the facility with the health plan.
Yeah, I would agree. Just adding a few comments onto that. I think what you'll see on the claims side somewhat often is some payers simply rejecting the question will be which one will they reject, but either the administration code or the E&M code if you're pairing the same ICD-10 code, saying that perhaps this should only be billed as one service when they're done on the same day. If they're just rejecting the med admin code routinely, that's not a huge amount of money, and that's probably not that big an issue, and you can continue with it, or your practice would be comfortable continuing with it. If you separate them out onto different days, they're almost certainly both going to be reimbursed. But that is as Amy mentioned, you may be making an 80-year-old come back to make sure you get maybe something like $18 to $23 reimbursed. So it's not huge amounts on that med admin code. The other thing to call out is a lot of times if you are administering same day, you might not get reimbursed for the Prolia, depending upon what the medical plan's criteria for access to that medication are. And that may be a big expense that doesn't get reimbursed, or it may take steps on the billing side to go through a retrospective prior authorization, which may be harder than a prospective. So unless it's something that that medical plan already covers without restriction, which I think most people do have PAs on Prolia due to the cost and alternatives that are there. And I want to clarify one more thing that kind of follows up on the question you had about, so let's say this is Medicare. Andy's right. If it's a Medicare B patient, this is going to be the best way to bill for this would be you perform it based on the referral, and you can point to the CDTM as the established plan of care, as long as it's written and detailed and specific. And then that encounter you have may be eligible to be billed by the medical provider who referred to you and is, or rather the medical provider who is present that day providing supervision. Their NPI goes on it as the rendering provider, and your services can be billed by that medical provider. If this is Medicare Advantage, if this is commercial, or if this is a Medicaid or managed Medicaid patient, you should be able to bill this directly with all of those codes as mentioned previously. Medicare Advantage, yes, has to cover the benefits package of Medicare Part B and generally follow those rules. So there are rules in Medicare Advantage law that prohibit Medicare Advantage plans from discriminating against pharmacists, well, not specific pharmacists, prohibited against discriminating against a provider type when a service is within their scope of practice. So in my practice, Medicare Advantage is one of my best payers. They're not the largest by number because we have a fairly young practice. So my Medicare percentage is less than 15%, but they are my highest reimbursement rate code to code and my highest percentage of claims paid as far as percentage of claims that get fully reimbursed.
So to clarify, since they are a Medicare patient, I could only bill incident 2, so the 99211.
Well, I think you noted that they were Medicare Advantage. So you could bill with your NPI as a pharmacist, and you could bill the full rates. You would not be limited to incident 2. Now, that doesn't mean they will reimburse you. Sometimes you have to fight a little bit and explain the law. But if it's within your scope of practice in Alaska, and it is a service covered by Medicare Advantage, it should be reimbursable, not as an incident 2 service.
Oh, okay. If it was a regular Medicare, it would have
Regular Medicare, just incident 2.
Okay.
Which, yeah, the 99211. Yep.
Okay.
Yeah.
And I know I want to be cognizant of everyone's time, but we do have one more question in the chat. So when the situation were to happen between a PCP at a clinic and a pharmacist in an independent community pharmacy, unrelated entities, would it be cleaner to have it on separate days, or does it, in a sense, cause a reset since the services being provided are 2 different entities or separate providers, or 2 different locations, separate providers?
This is actually a very tough question that I think could be argued either way. Andy has stated his opinion, and I think it's the most conservative and the safest opinion, is that if you're practicing under a CDTM, even though you're in a different entity, it's probably safest to bill that as an established patient. I think there's a case to be made for arguing that, yes, this may be a new patient because this is a completely different practice, assuming that at the new practice that pharmacist is employed by that practice. This is one of those areas where there really isn't a black and white answer. I think it comes down to your risk tolerance, though I would say it's probably safer to go with just assuming they're an established patient.
Perfect, thank you. And then one last thing, if anyone doesn't have any other questions, I know this came up this week and I had spoken to Zach about it, is how much insurance should an individual have for their LLC to ensure that they're covered for the non-dispensing services that they're providing? So in addition, they have pharmacy insurance or insurance at their pharmacy, but then also with their LLC, how much coverage should they have?
If you're providing immunizations as a pharmacy, you probably already have the appropriate insurance minimums as dictated by HIPAA and the high-tech law. If you're not providing immunization services, you might have to increase your liability coverage.
So with 2 separate institutions, so if they have an LLC as the separate one, would they have to have the same coverage at both, or would they have different coverage? So for instance, Justin created an LLC for his non-dispensing services, which he has another 3 million that he has coverage.
Yeah, you'd have to have a separate plan for that. Yeah, for that entity. It's a separate legal entity. They're completely distinct. So each is going to have their own plan. That's one of the considerations when you decide on whether or not you separate your clinical services out into a separate entity. We work with practices that independent pharmacies that are doing all their clinical services under just the same entity as the dispensing practice. And then you just need the one coverage, in which case, as Andy said, if you're doing immunization services, you're generally meeting the minimum requirements for both general liability and then professional liability. Another note is whether you're an owner or if you're just employed at that location too, you may want personal liability coverage as well.
Okay. And so just ballparking numbers, what coverage do you feel is appropriate?
Andy, isn't it roughly 2 million total?
I think it's 3 million total,
Right,
but
yeah.
I could be wrong. It's all federally defined, so it's something that you won't be credentialed unless you actually have proof or evidence of it.
Okay, so the minimum is the 3 million. Perfect. All right. I'm sorry, go ahead.
Go ahead.
Oh, I was just going to ask, just double checking if anyone had any last minute questions, and also to just remind people that if they have questions that come to them later, to put them into either email us and we can kind of get those together for the next time, and making sure that any questions that we have can be brought up at the next session.
This is super helpful. Thank you for your insight into this case. And then just one last follow-up, say this patient comes back in 6 months to get their next dose. That would just be the charge administration visit, then no E&M code.
Yes, so if there's already an established plan of care and you've already ordered the medication out, say for a year in advance, the med admin charge, the 96 code, is going to include basic background assessment to ensure it's appropriate to continue with an established plan. So if you then meet with them and you have to delay a dose, change to a different therapy, obviously that then becomes a full E&M encounter plus minus med admin. But if it's just continuing with the established plan and med admin without assessing new external lab work or other critical factors, it would just be that med admin code.
Perfect. So thank you so much again, Zach and Andrew, for your time. Thank you everybody for your active participation.